Hello, I'm Dr. John Iskander. Welcome to CDC Beyond the Data. I'm here today with Dr. Alex Crosby, Chief of the Surveillance Branch with CDC's Division of Violence Prevention.
Glad to be here.
Dr. Crosby, we heard at today's session about suicide prevention. Suicide, of course, is a profound personal tragedy, but to take a public health approach, we need to know something about trends at the population level. What can you tell us about those trends?
Suicide, that many people don't know, is the 10th leading cause of death in the United States. So it's responsible for over 40,000 deaths. And one of the other things is that since about 2006, suicide rates have been going up, primarily going up among working age adults, those 35 to 64. But you also see some increases among adolescents and young adults, those aged 15 to 24 too.
Now, are there other groups that have been found to be at higher risk for suicide, you know, specific populations of interest?
Definitely. Historically, when researchers have looked at the issue of suicide, that they have found that American Indians and Alaska Natives, especially in that population 15 to 34 years of age, have some of the highest suicide rates of any ethnic group. Also, when you look at other at-risk populations, you see that those who have been victims of violence, for instance, those who have been victims of child abuse and neglect, have higher rates of suicidal behavior. Also, non-fatal suicidal behavior, when they've looked at sexual orientation, those who have identified as gay, lesbian, or bisexual report many more suicide attempts than those that report heterosexual. So there definitely are some populations for which we need to be paying attention because their risk seems to be a little bit greater than the general population.
So really a very broad range of groups potentially at higher risk for suicide and, as you say, for suicidal behavior. I think many in our audience probably are familiar with some of the traditional risk factors such as mental health conditions, but we learned today that there is a broader group of risk factors. What can you tell us about those, and how have we learned some of this information?
One of the ways, and there's been a lot of research that has looked at a broader variety of things that can contribute or are associated with suicidal behavior. One of the ways is what's called the social ecological model. All that does is it tries to look at what are the individual level risk and protective factors, what are those that exist at the family and peer level as kind of a next layer, then at the community level, and then at the societal level. Oftentimes when folks have tried to look at suicide, they've focused very much at the individual level and very much focused on mental illness. As more research has been done, they have found that, for instance, there are risk factors at the family and peer level. For example, those within families where family is highly dysfunctional. Maybe there's a parent with substance abuse or a parent that has been lost due to death or due to incarceration, that those children are at higher risk. In addition, at the community level, you know, we've seen things like there's differences in geography even in the United States where we see higher suicide rates in the Rocky Mountain states, higher suicide rates there. In addition, we've looked at things like social isolation. Those that don't have a strong network of friends and family at greater risk for suicide. And it's one of the areas in which we've looked at the converse, which is the protective factor, and found that social connection or a stronger social support network is actually protective against suicide. So there are various things that, as research has expanded and tried to look at more of a public health approach rather than just solely a mental illness approach, that we find more about risk factors that allows us to do more in terms of our approaches and then also some of the prevention activities.
So I will just mention briefly for our audience that, in fact, one of today's presenters was from the Colorado Department of Public Health and Environment, and they showcase some very innovative strategies that they're working on. So as you point out, research has identified not only broader risk factors, but some protective factors as well. So I think one of the questions in many people's minds is suicide preventable? And if so, what works to prevent suicide?
There have definitely been some programs that have shown that they can prevent suicide. You know, there's several examples. One example is the program that was implemented by the U.S. Air Force back in the mid-90s. They were able to demonstrate by focusing on several different things in regards to treating the Air Force as a family or as a community, that they developed a community-level intervention there. And what they did is they were able to decrease suicides by 70%. Now, one of the things that they found is that maintenance and staying faithful to that particular program became an issue, that after they had seen that drop by 70%, some of the diligence to that program waned and suicide rates started going back up again, and then they had to come back and do it again. But definitely it demonstrated that you can prevent some suicides, you know, a drop by 70%. There has been some work that has been done with the Garrett Lee Smith Memorial Act, funded primarily through the Substance Abuse and Mental Health Services Administration, that has shown that gatekeeper kind of programs where you train people in the community to be on the lookout for folks that might be at risk, kind of a recognition and a referral type of program, that within those first 12 months, they show some statistically significant decreases in suicidal behavior. What happens is, again, you know, some of the effect wanes as some of the training goes away. And you may say, you know, there's a similar comparison to when people go and get, you know, CPR training. They tell you got to come back every couple of years to kind of refresh your skills, make sure that you're aware of, you know, any new techniques, any new things, and you forget some of the, you know, what you've done. But it's the same kind of thing with some of these programs too, that they show some initial decreases, initial prevention, but then you've got to maintain those programs and keep them up and make sure that people are aware. And, you know, as people move in and out of communities and things like that happen, that you've got to make sure that those kind of programs, you continue to keep them fresh in people's minds.
So, as with many things in public health, we really need to be on guard against complacency.
Absolutely.
But I think it's very encouraging that the examples you just gave spanned everything from interventions that occur on college campuses to interventions within branches of the armed forces. So, given some of these promising interventions, what does the future of suicide prevention look like to you?
I think there's a very bright future for suicide prevention. I think that it definitely faces challenges. You know, this is an area in which there are definitely limited resources, and that's across public health, that oftentimes there are challenges in getting resources for particular programs because there's, you know, competing interests, you know, where, you know, there may be a disease or a health condition here that needs some attention. You've got other ones that also need some attention. So there's definitely some of the challenges of resources. What's been shown, and I think this is part of what the research is doing, is much more evaluation now is going on of programs, scientific, rigorous evaluation where we can really look at outcomes and be able to demonstrate this program is really showing a decrease, or it's able to show that this program doesn't work, and so we're able to, you know, modify or do some other changes to that particular thing. So I think a strength that is now happening is much more outcome evaluation of programs. I think we're also improving our surveillance systems. You know, many states had to rely primarily on deaths and death certificate data, which have very limited information regarding circumstances and where the prevention activity might focus. But as we've expanded things like the National Violent Death Reporting System that puts together several different data sources, has information about circumstances on it, you know, there are programs and states that have been able to react to that information, be able to say, oh, we need to actually focus on a different population, or here's a risk factor. For instance, we found in some states that intimate partner problems are one of the leading precipitating events for suicidal behavior. Well, they were able to focus some of their efforts in that area. And so there are definitely some things that we've seen looking at non-fatal suicidal behavior, that as we expand some of our surveillance systems, we're able to identify those that have made suicide attempts, because the research has also shown us that that is one of the groups that is at greatest risk of dying by suicide, those who have made previous attempts. So now how can we intervene with those that have made attempts, and then how can we prevent those attempts from happening in the first place?
So as one of our speakers noted today, there is grounds for optimism for the future of suicide prevention.
Absolutely.
So I'd like to close by coming back to the idea that this is really both an individual level, a very personal problem that many people and many clinicians are struggling with, as well as public health people who may want to get more involved. Are there some resources both at the clinical or personal level and at the public health level that people where they can seek out more information?
Absolutely. Clinicians can oftentimes look to some of the larger organizations, whether that's, American Academy of Pediatrics, American College of Family Practitioners, that there's information there that helps train or resources available for those clinicians to be able to better identify their patients that might be at risk of suicidal behavior. So there are resources for clinicians. In terms of community organizations or those in the public that are trying to look for resources, there's the National Action Alliance for Suicide Prevention. Just a couple of years ago, under Surgeon General Regina Benjamin, we re-released an updated version of the National Strategy for Suicide Prevention. And within that document, there are a number of different opportunities for community organizations, for businesses, for public health departments, for schools, for correctional institutions, for a number of different places or organizations or institutions or disciplines to take action in regards to suicide prevention. And here's something that's relevant to the population that you might serve. So there are definitely some resources available.
Thank you very much, Dr. Crosby. Please join us next time for CDC's Beyond the Data.